I'm Vanessa Brooks, and I've been an emergency room nurse for 22 years at Metropolitan General Hospital in Chicago. In over 2 decades of working the night shift, I thought I had seen every possible way a human being could challenge medical expectations. I've worked trauma codes where patients survived injuries that should have been fatal. I've seen cardiac arrests where we brought people back after 20 minutes of CPR. I've witnessed recoveries that defied every medical textbook I studied in nursing school. But nothing in my training, nothing in my extensive experience, and nothing in the countless continuing education courses I've taken prepared me for what I witnessed on the night of November 15, 2019. It was a case that still makes me question everything I thought I knew about the boundary between life and death. And it's the reason I'm sharing this story with you today. Metropolitan General is a Level 1 trauma center serving Chicago's South Side. We see everything from gunshot wounds to heart attacks, from drug overdoses to domestic violence cases. The night shift, which runs from 7 p.m. to 7 a.m., is typically when we see our most challenging cases. People don't usually have medical emergencies during business hours, and by the time the sun goes down, we're dealing with the full spectrum of human tragedy and resilience. November 15th started like any other Friday night. I clocked in at 6:45 p.m., received a report from the day shift nurse, and began my rounds through our 12-bed emergency department. We had the usual mix of patients: a construction worker with a lacerated hand, a college student with alcohol poisoning, an elderly man experiencing chest pain that turned out to be severe acid reflux, and a young mother whose toddler had swallowed what she was convinced was a dangerous household chemical but turned out to be children's vitamins. Dr. Fiona Clark was the attending physician that night. She's someone I've worked with for over 8 years, and I trust her medical judgment implicitly. Dr. Clark is thorough, compassionate, and has an uncanny ability to diagnose complex cases that other physicians might miss. She's also someone who doesn't believe in medical mysteries. If something seems unexplainable, she'll keep investigating until she finds a rational, scientific answer. At approximately 2:30 a.m., our relatively quiet night changed when I heard the familiar sound of an ambulance siren getting closer to our emergency entrance. Within minutes, paramedics wheeled in a stretcher carrying an elderly woman who appeared to be in severe distress. The lead paramedic, Tom Bradley, whom I'd worked with countless times over the years, approached me with the patient information. "Found her unresponsive in her apartment," he said, his voice carrying the professional tone that masked what I could tell was genuine concern. "Landlord called for a welfare check after neighbors complained about a smell. No identification, no emergency contacts, no family that we could locate." I looked down at the woman on the stretcher. She appeared to be in her late 70s, with gray hair that had probably once been carefully styled, but was now disheveled and matted. She was wearing a faded floral dress that looked like it had been expensive once, decades ago. Her skin had that particular pallor I'd learned to recognize over my years in emergency medicine, the pale, almost translucent quality that indicates a body that's shutting down. "What's her presentation?" I asked Tom as we transferred her to bed 7, one of our monitored bays. "Vitals are weak across the board," he replied, consulting his notes. "Pulse is thready and irregular, blood pressure is 78/40, respirations are shallow and inconsistent. We got an IV line established, but she's been minimally responsive since we found her. No obvious trauma, no signs of overdose or poisoning. Just looks like someone who's been failing for a while and finally reached the end." I began my initial assessment while Tom and his partner gathered their equipment. The woman's pulse was indeed weak. So weak that I had to press firmly on her wrist to detect it at all. Her breathing was the shallow, irregular pattern I'd seen countless times in patients who were actively dying. When I lifted her eyelids to check her pupils, her eyes were unfocused and didn't track my movements. "Ma'am, can you hear me?" I asked, speaking clearly and directly into her ear. There was no response, not even a flutter of recognition. I tried a sternal rub, applying pressure to her breastbone to test for pain response. Nothing. This woman was deeply unconscious and appeared to be in the final stages of whatever process was shutting down her body. Dr. Clark arrived at the bedside as I was connecting the cardiac monitor. "What do we have, Vanessa?" I gave her the full report. Elderly female, found down in her apartment. No identification. Vitals consistent with someone in extremis. Tom says there was a smell in the apartment, which suggests she may have been down for a while before anyone found her. Dr. Clark nodded as she began her own assessment. She checked the patient's airway, listened to her heart and lungs, and examined her for any obvious signs of trauma or medical emergency. Her findings matched mine. This appeared to be an elderly woman whose body was simply failing. "Let's get blood work," Dr. Clark instructed. "Full metabolic panel, CBC, cardiac enzymes, toxicology screen, and let's get a chest X-ray and see if we can get any information about her medical history." As I drew blood and prepared the woman for her X-ray, I noticed something that struck me as both sad and significant. Despite her condition, someone had clearly taken care of her appearance recently. Her fingernails were clean and neatly trimmed. Her hair, though disheveled now, showed signs of having been professionally styled within the past few weeks. Even her faded dress was clean and had been carefully pressed. She wasn't homeless, I mentioned to Dr. Clark as we reviewed the preliminary lab results an hour later. Someone was taking care of her, or she was taking care of herself until recently. "I agree," Dr. Clark said, looking at the chest X-ray that had just come back. "And her labs are actually not as bad as I expected. No signs of acute organ failure, no obvious infections, no drug overdose. It's like her body just decided to start shutting down." We ran the usual protocols for patients with unknown medical histories. Social services were contacted to try to identify her and locate any family members. The police checked missing persons reports. We even had security review the surveillance footage from the apartment building to see if there were any clues about what might have caused her condition. Meanwhile, I continued monitoring her throughout the early morning hours. Her condition remained stable but grave. Her pulse stayed weak and thready. Her blood pressure hovered in the low range, which indicated her cardiovascular system was struggling. Most tellingly, she remained completely unresponsive to any stimuli. At 3:15 a.m., I documented what I expected might be my final assessment of this unknown woman. "Patient remains unresponsive," I wrote in her chart. "Vital signs consistent with end-stage condition, no family identified, appears to be actively dying, comfort measures only." Our hospital has a policy for patients like this. Elderly individuals with no identification and no family who appear to be in their final hours. We don't perform aggressive interventions, but we ensure they're comfortable and not alone. It's one of the more difficult aspects of emergency nursing, but it's also one of the most important. Nobody should die alone, even if we don't know their name. The emergency department was particularly busy that night, which meant I was managing 5 other patients in addition to the elderly woman in bed 7. I checked on her every 20 minutes, noting any changes in her condition and ensuring she appeared comfortable. Each time, her status was the same: unconscious, weak vital signs, no response to stimuli. At 4 a.m., I was in the middle of starting an IV on a patient with severe dehydration when I heard a voice I didn't recognize. "Excuse me, nurse." I looked up from my work, expecting to see a family member or visitor. Instead, I saw an elderly woman standing in the doorway of the trauma bay, the same elderly woman who should have been unconscious in bed 7. But this wasn't the same person I'd been monitoring all night. The woman standing before me was alert, upright, and fully dressed in the same floral dress, which now looked neat and properly arranged. Her hair was combed, her posture was straight, and her eyes were bright and focused as they met mine. "I'm feeling much better now," she said, her voice clear and strong. "And I'm quite hungry. Is there somewhere I might get a bite to eat?" I stood there for several seconds, unable to process what I was seeing. This was medically impossible. The woman I'd been caring for had been unconscious and dying just minutes earlier. People don't recover from that kind of condition by simply standing up and asking for food. "Ma'am?" I said, my voice probably betraying my confusion. "You should be in bed. You've been very ill." She smiled, a warm, genuine expression that transformed her entire appearance. "Oh, I know I was feeling poorly earlier, but that seems to have passed. I really am quite hungry, though. I don't think I've eaten since yesterday morning." I immediately checked bed 7, thinking perhaps there had been some kind of mistake, that maybe we'd had another elderly patient admitted that I'd somehow forgotten about. But the bed was empty, and the cardiac monitor that had been showing her weak, irregular heart rhythm was now displaying a flat line because no patient was connected to it. I quickly called for Dr. Clark, who arrived within seconds. Her reaction mirrored mine, a moment of stunned silence followed by immediate medical curiosity. "Ma'am, I'm Dr. Clark," she said, approaching the woman with the careful manner we use with patients who might be disoriented. "Can you tell me your name?" "Lucille," the woman replied without hesitation. "Lucille Harper, and I must say, you have a very nice facility here. Everyone has been so kind to me." Dr. Clark and I exchanged glances. This was the first identification we'd gotten for this patient, but more importantly, Lucille Harper was standing before us, appearing completely healthy after having been unconscious and dying less than an hour earlier. "Lucille, I need to check your vital signs," Dr. Clark said. "Can you sit down on this bed for me?" "Of course, doctor." Lucille climbed onto the examination table with no assistance and no apparent difficulty. Her movements were smooth and coordinated, nothing like someone who had been unconscious for hours. I connected the blood pressure cuff and placed the pulse oximeter on her finger, while Dr. Clark prepared to listen to her heart and lungs. The numbers that appeared on the monitor made me check the machine twice to ensure it was working properly. Blood pressure, 128/80, perfectly normal for a woman her age. Heart rate, 72 beats per minute, strong and regular. Oxygen saturation, 98% on room air. These weren't the vital signs of someone who had been dying an hour earlier. They were the vital signs of a healthy elderly woman. "Lucille," Dr. Clark said as she completed her physical examination, "do you remember how you got here tonight?" Lucille thought for a moment, her expression showing genuine concentration. "I remember feeling very tired and unwell yesterday. I think I may have fainted because the next thing I knew I was waking up here, but I feel fine now, really, quite well." Dr. Clark's examination was thorough and her findings were completely normal. Lucille's heart sounds were regular, her lungs were clear, her neurological responses were appropriate, and she showed no signs of the medical distress that had characterized her condition throughout the night. "Would you like something to eat?" I found myself asking, still struggling to process the situation, but responding to her original request. "That would be wonderful," Lucille replied. "I don't want to be any trouble, but I am quite hungry." I walked to our staff break room, feeling like I was moving through a dream. In the small refrigerator, I found a sandwich and a container of soup that one of the day shift nurses had left behind. I heated the soup in our microwave and arranged everything on a tray, still trying to understand what was happening. When I returned, Lucille was sitting comfortably on the examination table, chatting with Dr. Clark about the weather and asking thoughtful questions about our work in the emergency department. She seemed genuinely interested in our responses and made several insightful comments about healthcare that suggested she had some familiarity with medical settings. I set up a bedside table and helped Lucille get comfortable in the reclining chair next to bed 7. She thanked me with genuine warmth and began eating with obvious appetite. As she ate, she continued our conversation, asking about my family, commenting on how dedicated healthcare workers must be to work night shifts, and sharing her appreciation for the care she'd received. "You know," she said at one point, pausing between spoonfuls of soup, "I've always believed that nurses are the real heroes in hospitals. Doctors get most of the recognition, but nurses are the ones who actually take care of people." It was exactly the kind of comment you'd expect from someone who had spent time in healthcare settings, either as a patient or perhaps as a family member of someone who had been ill. Lucille spoke with the insight of someone who understood how hospitals worked and appreciated the roles different professionals played. Dr. Clark and I kept exchanging glances throughout this entire interaction. We were both experienced medical professionals who had seen unexpected recoveries before, but nothing like this. Patients don't go from actively dying to completely normal in the space of an hour. It simply doesn't happen. "Lucille," Dr. Clark said gently, "I'd like to keep you here for a few more hours, just to make sure you're stable. Would that be all right?" "Of course, doctor. I understand you need to be careful. I don't want to cause any problems." As Lucille finished her meal, I found myself studying her carefully. This was definitely the same woman who had been brought in by ambulance earlier that night. She had the same facial features, the same build, even the same small scar on her left hand that I'd noticed during my initial assessment. But everything else about her was completely different. The woman from earlier had been unconscious, unresponsive, and clearly dying. Lucille was alert, engaging, and showed no signs of medical distress whatsoever. Her color was good, her breathing was normal, and she moved with the easy confidence of someone who felt well. At 5:30 a.m., Dr. Clark called me aside to discuss the case. "Vanessa, I've been practicing medicine for 15 years, and I have no medical explanation for what we just witnessed." "I've been thinking the same thing," I replied. "I've documented her condition throughout the night. Her vital signs, her level of consciousness, everything indicated she was actively dying. And now she's sitting there asking if she can help us with anything because she feels bad about taking up our time." "I want to run some additional tests," Dr. Clark said. "Blood work, EKG, maybe a CT scan if she'll agree to it. Something happened here that's outside my medical experience, and I need to either find an explanation or document that we can't find one." Lucille was cooperative with all the additional testing. Her blood work came back completely normal, better than normal actually, for a woman her age. Her EKG showed a regular heart rhythm with no signs of previous cardiac events. Even a CT scan of her brain was normal, with no signs of stroke, bleeding, or other abnormalities that might explain her earlier condition. But as we were reviewing these test results around 6 a.m., I noticed Lucille yawning. "I think I'd like to rest now," she said, her voice carrying the first hint of tiredness I'd heard since she'd recovered. "I'm feeling rather fatigued, and I imagine you need this bed for other patients." "You're welcome to rest here as long as you need," I assured her. "We're not in any hurry to discharge you." Lucille smiled and thanked me again. "You've all been so kind. I hope I haven't been too much trouble." I helped her get comfortable on the examination table, adjusting the pillow and pulling a blanket up to her chin. She settled in with a contented sigh, like someone who was genuinely tired and looking forward to sleep. "Will you be able to rest with all the activity out there?" I asked, gesturing toward the main emergency department, where we could hear the usual sounds of a busy night shift. "Oh, yes," Lucille replied, her eyes already beginning to close. "I'm a very sound sleeper. Thank you again for taking such good care of me." Within minutes, she appeared to be sleeping peacefully. Her breathing was slow and regular, and she looked comfortable and relaxed. I dimmed the lights in the bay and closed the curtain to give her privacy. At 6:45 a.m., I was preparing for the change of shift when I decided to check on Lucille one more time before giving the report to the day nurse. I approached her bed quietly, not wanting to wake her if she was still sleeping. But as soon as I looked at her, I knew something was wrong. Lucille was lying in exactly the same position I'd left her in, but her face had changed. The healthy color was gone, replaced by the pale gray hue I recognized from my years of working with critically ill patients. I immediately checked her pulse. Nothing. No heartbeat, no breathing, no response to stimuli. I called for Dr. Clark, who arrived within seconds and confirmed what I already knew. Lucille Harper was dead. Not dying, not unconscious, not in medical distress. She was dead, and based on the appearance of her body, she had been dead for some time. Her skin was cool to the touch, her pupils were fixed and dilated, and rigor mortis was already beginning to set in. Dr. Clark and I stood there in silence for several minutes, trying to process what had happened. Less than 2 hours earlier, this woman had been eating dinner, having normal conversations, and showing every sign of being completely healthy. Now she was dead, with no apparent medical event that could explain the transition. "What time did she fall asleep?" Dr. Clark asked. "About 6 a.m., I replied. "She said she was tired and wanted to rest. I helped her get comfortable and she seemed to fall asleep normally." "And when did you last check on her before now?" I thought back through the events of the morning. I haven't looked in on her since I helped her settle in. That was about 45 minutes ago. Dr. Clark began the process of officially pronouncing Lucille dead, including documenting the time and apparent cause. But even as we followed protocol, both of us were struggling to understand what had happened. The official cause of death was listed as cardiac arrest, which was technically accurate but didn't explain anything about the circumstances. Lucille had died peacefully in her sleep, which is what many people hope for when they think about their own deaths. But the medical events that preceded her death were unprecedented in both of our experiences. Over the following days, I found myself thinking constantly about Lucille Harper. I reviewed her chart multiple times, looking for some detail I might have missed, some medical explanation that could account for her impossible recovery and subsequent death. I consulted with colleagues who had decades more experience than I did. I researched medical literature looking for similar cases. I even spoke with specialists in geriatric medicine, hoping someone could provide insight into what I had witnessed. Nobody could offer an explanation that accounted for all the facts. A patient doesn't recover from the kind of condition Lucille had presented with earlier that night. People don't go from actively dying to completely healthy, and then back to dead within the space of a few hours. It simply doesn't happen, according to everything we understand about human physiology. But it did happen. I witnessed it, Dr. Clark witnessed it, and we documented every aspect of it in Lucille's medical record. About a week later, we finally received some information about Lucille's background. The social services investigation had located a distant nephew who lived in California. According to him, Lucille had been a registered nurse herself, working for over 40 years at various hospitals throughout the Midwest before retiring to Chicago to be closer to a sister who had since passed away. The nephew said Lucille had been living alone for the past 3 years and had been gradually declining both physically and mentally. He had been considering moving her to assisted living, but Lucille had insisted she was managing fine on her own. She was always very independent, he told us over the phone, and she was proud of her career in nursing. She used to say that she understood medical situations better than most people, and she didn't want to be a burden on anyone. This information added another layer to an already mysterious case. Lucille had been a nurse, someone who would have understood exactly what was happening to her during those final hours. She would have recognized the signs of her own body shutting down, and she would have known that her recovery was medically impossible. I wondered if that explained her calm acceptance of the situation. When she woke up feeling better, she didn't seem surprised or confused about her condition. She simply accepted that she felt well and made the most of the time she had. Lucille Harper died on November 16, 2019 at 6:30 a.m., according to the official death certificate. But I believe she actually died twice that night, once when her body began failing in her apartment, and again when she peacefully passed away in our emergency department after sharing one last meal and conversation with people who cared about her well-being. I've been working in emergency medicine for 22 years now, and I've learned to trust medical science and evidence-based practice. But Lucille's case taught me that there are aspects of human experience that our training doesn't address and that our scientific understanding can't fully explain. I still work the night shift at Metropolitan General, and I still approach every patient with the same professional dedication I've always maintained. But I also pay closer attention now to the moments that seem to transcend medical explanation. The recoveries that shouldn't happen, the peaceful deaths that come at just the right time, and the small miracles that remind us that healing involves more than just treating symptoms. Lucille Harper's case remains officially unexplained in our hospital's medical records. But for me, it serves as a reminder that emergency nursing is about more than just medical procedures and clinical protocols. Sometimes our most important role is simply being present with people during the most significant moments of their lives, even when those moments don't make medical sense. I think Lucille knew she was dying that night. I think her recovery was her way of saying goodbye, not just to life, but to the profession she had dedicated 4 decades to serving. She spent her final hours talking with nurses, appreciating our work, and reminding us why we chose this calling. And then, when she was ready, she let go. In 22 years of emergency medicine, it was the one case that taught me that the boundary between life and death is not always as clear as our medical training suggests. Sometimes there are moments of grace that allow people to complete their journey in their own way, on their own terms. Lucille Harper had her final dinner, shared her appreciation with people who understood her life's work, and then departed peacefully. If that's not a medical miracle, it's at least a profoundly human one. I've never forgotten her, and I never will.